And now we have the next speaker, Jitendar Sharma from India. He will speak about digital health in COVID-19 and beyond in India. Jitendar, the floor is yours, please.
Thank you, Pedro, my friend, and thanks for this opportunity. I may like to get away with the excuse that I did not have sufficient time for this webinar as an excuse for not giving a presentation on PowerPoint, but I will briefly share my thoughts on what's happening and what can be done together. Use of artificial intelligence, machine learning, computers, programs has not been new to healthcare. We have legends here. Elliot, for example, almost fathering several programs across many nations, particularly in the US, supporting health systems. But what has been new is the acceptance in the health systems, particularly those funded by public funds, that telemedicine, teleconsultation, teleprescription, and telemonitoring is now a non-negotiable part of how we provide for care. You would see in many countries, including India, for example, that telemedicine, while it was considered as a top-up on a beautiful, progressing health facility, it was not considered an essential characteristic. It was nice to have, not must have. COVID has actually balanced that formula by letting us know that it's a must have. And I will give you 3 examples of where we are associated with, in particular as AMTZ, because we supply almost 1 million RT-PCR kits every day for national needs, about 400 ventilators, oxygen concentrators, etc., from my own publicly funded medtech manufacturing park to the rest of the country. We have now integrated thermal scanning, temperature monitoring with the CCTV cameras. We produce it about 120 units every day. I don't have on this computer because I'm in a different location and not in my office, but we brought out thermal imaging as part of CCTV camera for 2 reasons. One, for high density footfall places where we have lots of people in one location at a given time, and to ensure that without going close enough to the person, we could actually take temperature. And guess where we deployed this? We didn't deploy this innovation that we did in hospital first. We deployed it in India's busiest railway station. That's the railway station of the New Delhi, the capital city of the country, which sees about, in non-COVID times, and don't be surprised, it sees about 1.2 million passengers crossing the railway station every day. In COVID, it's 350,000 passengers that crosses that railway station every day, because it's the central railway station in the capital of the country. Now this has been picked up as an innovation by the Railway Police Protection Force and the Railway Traffic Agency, where they are taking from us the CCTV integrated with thermal imaging, all managed by AI in the Railway Protection Force and the Railway Traffic Systems control room through the thermal cameras, where they pick thermal images, alert patients, and so on. This is a classic example of what we have done using AI, sensors, the medical technology available in surveillance and monitoring. The second example is in diagnostics. The RT-PCR COVID tests, the law states that a microbiologist has to report the test. Although it's the machine which is doing the test, the reporting of the test has to be done by a qualified microbiologist. Now, no country would have microbiologists at every point of test. They are rare. not as rare perhaps as anesthesiologist or radiologist, but still rare. They are not available in the same numbers, which is like general physician. Entire RT-PCR testing that we do has two parts. One part is in hospitals, and the second part is in mobile buses that we build with biosafety level cabinet 2, biosafety level 2 cabinets inside the bus, with completely inbuilt with air handling units and sample protection systems, etc. Now these buses, they carry an entire RT-PCR system built in a container to remote villages. Now, we cannot really take microbiologists to those destinations because their workload is immense at central locations. Now, entire RT-PCR testing in mobile systems using mobile trucks and buses, the reports are sent using tele-diagnosis protocols to the central location where it's the microbiologist and the central location that's the reporting. Now, with this mechanism, we are able to actually do more than 150,000 tests, which is like 10% of testing that happens in India every day. So almost 10% of testing, which is entirely in remote areas, actually now uses RT-PCR combined with telecommunications, combined with the clinical excellence brought in by the microbiologists, only because we have telecommunication system also integrated in this mobile RT-PCR vans. That's the example on diagnostics, which is the next stage to surveillance. And most importantly, as you all know, the vital parameters monitoring in critical care units. Again, I'm sorry for not being able to give a beautiful presentation, but I'm just showing you the picture. I don't know if you can see my picture. These are mobile containers which we build as hospitals, 8-bedded hospitals, fitted with ventilators, oxygen concentrators, pipelines, and everything that a hospital needs. These containers are then taken in trucks to remote locations and this container has actually left our facility 4 days ago. Today it's in a place which is 3,000 kilometers, about 2,000 miles from where we are, in settings which do not have hospitals. These are COVID hospital containers, integrated completely with modern technology, portable on trucks, on goods train, which we ship to multiple locations in the country. An entire vitals monitoring in these containers at multiple locations actually happens through our AI softwares that are integrated with multi-para monitors, picking vitals, taking the vitals to the teleconsultation centers where these consultants, clinical experts can actually advise the paramedical professionals, general physicians and nurses handling the patients remotely, real-time prescription, vitals monitoring, and teleclinical support. So I have given 3 examples, all 3 that we actually do, right from thermal imaging in railway stations, built and supported by us, provided by us in railway stations, as example of surveillance, the RT-PCR vans, which are using AI and bridging the gap of microbiologists between the site of testing and the place, a central place from where reporting happens, as example of diagnostics, and container hospitals, which allows teleconsultation, again backed by AI, as an example of clinical care. When you put these 3 things together, we are actually putting surveillance, diagnostics, and clinical care together, the triangle of care together, at the center of which is digital health. It is the core digital health that is helping us bridge these gaps in accuracy, in testing, in reach, in affordability, and most importantly, in geographical accessibility. So apologies for not giving a PowerPoint presentation But these three examples are live there, happening as we speak, being supported by multiple biomed technicians, engineers, ensuring that digital health is not just an idea to be executed singularly in a silo, but something that can actually combine our true potential, bringing service delivery, digital health, and indigenization of technologies together, ensuring rapid, accessible, affordable care. Thank you once again for the opportunity. Thank you to Tom. Thanks to Tom and to all my colleagues up there for the brilliant work. And over to you.
Unbelievable job, Jitendar. Thanks.
Thank you, Jitendar, for your very interesting presentation. Yes, thank you for your presentation, Jitendar, and very interesting experience in India, how we can use digital health to integrate all the other services in the health sector. And before we move to the next speaker, I will say you please use the Q&A tab to formulate your questions. We will before make the 6th presentation, and after that we will answer your questions.